titled Chronic Pain, Negotiating the Evidence Maze. Okay, so we would like to acknowledge everyone who's in here, like our academic staff, okay, our chairperson, Dr. Reda Dashti. Of course, the presence also of our external stakeholders from Salmania Medical Hospital and primary healthcare centers of the Ministry of Health, and also the presence of our staff from King Hamad University Hospital, and as well as people from Bahrain Defense Force Military Hospital. I would like also to acknowledge, of course, our beloved students who are here to attend this wonderful seminar. Okay, let me introduce our speaker for today. Our main speaker is a senior lecturer and a researcher in the College of Health and Life Sciences under the Department of Clinical Sciences at Brunel University. He divides his time between research and training new physiotherapists and previously worked extensively as a musculoskeletal physiotherapist. Our presenter's main research interests are chronic low back pain and chronic pain more broadly with a focus on evidence-based practice. He has conducted numerous systematic reviews and is an editor for the Cochrane Collaboration's Pain, Palliative, and Supported Care Group, and is a member of the Guideline Development Group for the UK's National Institute of Health and Care Excellence forthcoming guideline for the management of low back pain and sciatica. Good morning, everyone. Let's me introduce our speaker for today, Dr. Neil O'Connell.
Thank you, everyone. How lovely to see you all, and it's such an honor to be invited to come and speak. And I'm amazed. I've never had a banner before. This is new. My wife won't believe it. So I am a physiotherapist by background, but I don't practice clinically at all anymore. I work full-time at Brunel, and when I'm not teaching physios, I'm working on my research, which is largely based with the Cochrane collaboration. Is everyone familiar with the Cochrane collaboration? Yeah, good. Well, we'll talk a bit about what we do there in a second. When I'm not doing Cochrane reviews, I'm senior commissioning editor with the pain science blog Body in Mind. Have any of you seen bodyinmind.org? It's a blog set up by Professor Lorimer Moseley, the pain specialist from University of South Australia. And what we try and do there is to present contemporary pain research in a format that's accessible for clinicians and for patients. And so if you get the time, it's worth having a look. And as was said in my introduction, I've also recently been working with the National Institute of Health and Care Excellence, working on a clinical guideline for back pain, which, if anyone's interested, will be published on Wednesday morning, UK time, this week. And that's a very important document because, with luck, if it's implemented, it should guide the future, at least for the next 10 years or so, of back pain care in the UK. And not just rehabilitation, but medical, surgical, and other interventions as well. And so I'm talking to you today about persistent chronic pain. And that's a very challenging topic. By virtue of the fact that patients have persistent pain, these are people that tend not to respond to treatment. These are people that tend not to improve when we intervene, and that's where they're at by the time they get to the clinic. And that can be very frustrating for clinicians. And it's odd that I'm talking about it, really, because you'd only need to search Google for chronic pain and cure to know that there's lots of cures available for chronic pain. So why need we worry? So these are just the first 20 or so things I found on Google when I Googled chronic pain and cure. We have CDs where you can play subliminal messages while you sleep to cure your pain, a number of leaflets, an inversion table, and apparently all these things cure chronic pain. But really, that's not reflective of the truth. Chronic pain management is a minefield. For the patient with persistent pain, they are faced with a huge range of potential treatment options. Each of those options is backed by an enthusiastic advocate a clinician, or an alternative health practitioner. And those people will say that their treatment is evidence-based, that there is evidence for their treatment, and that it is effective. So how does the person with persistent pain choose? Because if you ask them, well, why is it evidence-based? They will find you a paper that seems supportive of that. But that isn't evidence that a treatment works unless that paper is robust, unless it's high quality, unless perhaps more than one research paper supports that answer. And so we have a big problem when people talk about their treatments being evidence-based, that people have a tendency to cherry pick. And they cherry pick just those pieces of evidence that appear to tell the story that their treatment is effective. And what they tend to do, and we all do this to some extent, is to ignore those pieces of research that don't. And that's a big problem. And that's really the problem that the Cochrane collaboration was designed to try and address. That we didn't have, prior to systematic reviews, a systematized, clear and transparent approach to getting all the best evidence together, to critiquing that evidence and to coming up with a good answer. How much do we know about whether or not these treatments are safe and effective? And so Cochrane is an enormous organization now, many years on from its inception, and it's split into different review groups. And the review group that I work with is the Cochrane Pain, Palliative and Supportive Care Group. And we look largely at persistent pain, neuropathic pain, and end-of-life and supportive care. And the problem, and you guys all know this, so it's useful to talk about this again just to introduce and set the scene. The reason we can't really tell whether our treatments worked is that people get better. And people get better often regardless of what we do. And people get better sometimes despite what we do, which is a harsher lesson. So the patient with the acute condition may come into the clinic. So let's take, for instance, I notice every time I turn my head to look at the screen, the microphone can't hear me. What I might do is this. That's better, isn't it? So if we take a patient with acute back pain and they come into the clinic here and they're at their worst, and so we do our assessment and we decide what their problem lists are and we devise our treatment, and then we follow them over the next 3 or 4 weeks and their symptoms improve. And this is fantastic. This is one of those life-affirming moments when we realize why we came into the profession. Because at the end, the patient is better. But the truth of the matter is, this red line actually represents what would have happened to the patient with acute back pain, regardless of whether we'd intervened. Take this as a potential example, and it's entirely hypothetical. Maybe the green dash line is what happened with our treatment, and the red line is what would have happened without our treatment. We'll follow the patient up, and we'll take credit for a 30% improvement in their symptoms. But what's actually happened here, the red shaded area, represents how much we've harmed the patient, and we'd never know. And, I think sometimes when the debate about evidence-based practice, it goes round and round because it is challenging. We forget this very basic fundamental truth that we wouldn't be able to measure harm in most acute patients because their trajectory would be quite positive. It works both ways, though. So let's take a patient whose natural history of their symptoms is a worsening of their symptoms, a progressive disease. And let's say we intervene. And this is the outcome. The green dash line is the outcome. So the red shaded area here represents how much we have specifically helped the patient. And it's perfectly possible that this is a clinically important difference to that patient's life compared to what would have happened had we never intervened. But what we would see in the clinic is the patient saying, I'm worse than I was when you started. So we might abandon our treatment and just stop doing it. Of course, most conditions aren't neat. Most persistent conditions are wonky. They follow a strange and fluctuating path, which makes it even harder to determine whether we really are having an effect in practice. It's perfectly possible that we might intervene in someone's symptoms. Let's say these are the symptoms of a patient with fibromyalgia, whose symptoms are classically fluctuating but often severe. And if we intervened and the green dash line is the outcome of that, then I think you would suggest that we've made an important difference to this patient's lives. The peaks are less high. The flare-ups aren't as bad. But what we might see the patient reporting is their pain is still up and down. And it's not necessarily obvious that we'd be able to detect that. And of course, it could work in the opposite way. This could be the outcome. But again, we're making the patient worse in this situation. We're harming the patient, but we might not be able to detect it in the clinic. Put simply, if we had an effective treatment and compared it to an entirely pointless treatment, a piece of therapeutic theatre, if we take our effective treatment, it's still not going to work in everyone all the time. So in our effective treatment, we roll it out for a specific condition. Let's say 4 patients have a good recovery, 3 patients experience little change, and a few patients get worse. And there's all sorts of reasons that might happen. It may be that they're having a difficult moment in their life. It may be that while they've received the treatment and adhered to some of it, they've done a few things that aggravated them. It may be any number of reasons because life is so complex. And then let's look at our ineffective treatment. Well, some patients are going to do well regardless for any number of reasons. Maybe they got a job that they really love, or maybe their life has changed in some substantial but unmeasurable way that we don't know about. And many with an ineffective treatment won't change at all, and some will get worse. It may be that the treatment made them worse, but more likely they were just going to worsen anyway. Now, the question then is, in the clinic with the patients in front of you, would you really be able to detect that effective treatment? And you might argue that you could, but it might be the equivalent of seeing a face on a rock formation on Mars, that you're seeing patterns in the noise, but you can't be confident that they really are true patterns. There's far too much text on this slide, and I apologize for that, but it's a quote that I think sums up the whole problem in terms of trying to judge whether our treatments are effective. And the problem is that everyone wants the same thing. So the medical philosopher, the late Sir Peter Medawar, once wrote, "The exaggerated claims for the efficacy of a medicament are seldom the consequence of any intention to deceive. They're usually the outcome of a kindly conspiracy in which everyone has the very best intentions because the patient wants to get well, the doctor wants to have made him better, the drug company would like to have put it into the doctor's power to have made him so. And the controlled clinical trial is an attempt to avoid being taken in by this conspiracy of goodwill." I think that's just a beautiful quote because it sums it up entirely. When we're trying to work out whether treatments work or are harmful, we're having to do that through this maze of different competing biases that make it very hard for us to tell. And so, of course, the model to tell is to do a randomized controlled trial where we take a bunch of people that fit our criteria and we take baseline measures and we randomize them to our intervention and a likely relevant control that might be placebo or no treatment or usual care. And we follow them up over time after the treatment, and in chronic conditions, you really need to follow people up over time. These are symptoms that last for a long time. So just measuring people immediately after the intervention isn't awfully helpful. And the difference on average in symptoms or outcome between the two groups, that is our best estimate of the effect of the treatment, and really the only estimate where we can draw a causal inference and say, yes, the treatment caused that outcome. And that's, of course, why RCTs sit at the top of the evidence pyramid, and the only thing that sits on top of an RCT on the evidence pyramid is all the RCTs, all the randomized controlled trials. And everyone's familiar with that. There is a phenomena in research, and we're all taught it at undergraduate level. Everywhere in the world we're taught this at undergraduate level, and it's a shame because it isn't really true. And that is that a p-value tells you that your experiment was successful. And everyone's familiar with p-values, yeah? So the probability, I mean, in lay terms, the probability that any result that you're seeing might be a false positive. So we have this convention where we accept a p-value of statistical significance of less than 0.05 as the marker of a positive trial. And it's missing something really important. And that is that I may well have a statistically significant benefit to patients. It's reliable enough that it didn't happen by chance. But that doesn't mean it's important to the patient. It doesn't mean it's changed their life in a meaningful way. And ultimately, we're not interested in whether our treatments are statistically reliable. Well, we are, but we're more interested in whether they're helping people, whether they're changing people's lives. And that's led us to move to considering beyond the p-value what makes an important difference. And there's been loads of work on this in pain. And what's fascinating is there's still very little agreement. So the impact group came up with some international consensus recommendations for how much improvement would a patient need to see for that change to be important to them. And they did it by benchmarking percentage in change in pain by another measure of global perceived recovery. And they decided that anything more than a 15% improvement in pain would reflect an important change, but only just. It's a minimally important change. Greater than a 30% improvement in pain, a moderately important change, and greater than 50% improvement in pain, a substantially important change. And less than 15% improvement, not really worth writing home about, not really anything important at all. So we should question this, though. This is a consensus statement from many, many very world-renowned researchers and clinicians. But that doesn't necessarily mean it's right or that it's defensible. It just means that it's a consensus of the day. So Rob Herbert, who's a physio researcher from Sydney, and Manuela Ferreira, who is also a physio researcher from Sydney, wrote a lovely review paper about clinically important differences a few years ago. And they came up with a list of things that they think are desirable for what a clinically important difference threshold should be. Now, the first thing it should do is shift our focus away from the p-value, because that's not that important, to the effect size. And of course, the impact thresholds do that. They make us think about how much change there were. But the next point they make is, surely a clinically important difference would be specific to the type of intervention that you're delivering. So I might require a lower improvement in pain to take an advice leaflet and a chat with a clinician than I would want if I signed up to have my spine fused or to have a very invasive denervation procedure. So these thresholds aren't. These thresholds are generic thresholds to be used across pain research. And that's a flaw, really, because you wouldn't necessarily require the same amount of improvement. It would depend on the costs and the risks and the inconvenience of that intervention that you're signing up for. We'd ideally want them to be population specific. Someone with acute back pain may think that an important change is less than someone with chronic back pain, or someone with persistent neuropathic pain, or cancer-related pain. And it's important that we try and make, if our research is truly to be patient-centered and patient-informed, then it needs to reflect the patients that we're seeing, not some strange estimate of all the patients we could possibly be seeing. And lastly, it needs to be based on treatment effect and not outcome. Because outcomes, as we saw in the first couple of slides, aren't the same as treatment effects, because patients get better and patients sometimes get worse, regardless of the treatment. And this type of clinical threshold doesn't do that, because we're looking at how much that patient changed from baseline. As we've already said, that's going to reflect natural history of the condition. It's going to reflect non-specific treatment effects like placebo effects and contextual effects. It's going to represent the statistical phenomena of regression to the mean. And it's going to represent, possibly, if there is one, a specific treatment effect as well. But what I thought I'd do is I'd go through the Cochrane library and I'd cheat a bit. I'd cherry pick interventions for chronic low back pain, first of all, that seem to be effective, that have statistically significant benefits at least. And what I've done is I've represented the effect size as percentage improvement compared to what happened in the control group, just to get a sense of where they sit next to the impact thresholds. So I'm sorry the bottom of my slide has cut off a little, but here we have Pilates versus minimal care or usual care, and we have just shy of a 30% improvement. Here we have multidisciplinary biopsychosocial rehabilitation. Now, this is really interesting, I think. This is complex interdisciplinary pain management programs, which are lengthy, absolutely considered to be best practice. They're quite expensive. Sometimes they're even residential. And you can see the effect size is, I don't know where my laser's gone, there it is, not as high as perhaps we would like it to be. This is tramadol, the opioid versus placebo. This is strong opioids versus placebo. Is anyone surprised by that? Opioids seem to carry with them this wonder drug brand that they're effective for chronic pain. There is now an emerging consensus that they really aren't very effective for chronic pain, but they are profoundly risky for chronic pain. I can't talk about the new draft, the new NICE guideline until it's published on Wednesday, but the draft of the NICE guideline is a public document, so I can talk about that. And that recommended not to use opioids in chronic back pain at all. This is manual therapy versus another intervention. And if there are manual therapists in the crowd, I must say I'm a manual therapist too, so this doesn't please me. And you may think that I've been a bit harsh on manual therapy by choosing the comparison where it's compared to another intervention rather than no treatment or sham. But the reason I chose that is because that was the only comparison that was statistically significant. So versus sham, although sham is hard to do, it doesn't really show an effect. And this last one here is cognitive behavioral therapy versus awareness control. The reason I show you the slide is to show you that actually across the board, things are pretty similar for chronic back pain. Everything seems to work a little bit. Nothing seems to work very much. But as we've said, those thresholds are based on within-person change, and the only measure we have of the actual specific treatment effect is the between-group change after treatment. So it would be interesting to know, well, what would a clinically important difference look like based on that change? And it's really hard to derive. So the OMERACT 12 group have recently come up with a recommendation, and it isn't profoundly evidence-based, it's really a consensus evidence base of anything more than a 1-point change on a 0 to 10 pain scale represents a clinically important difference. I'd be very interested in knowing what you think about that. So let's have a vote. Put your hand up if you think that a 1-point change on a 0 to 10 pain scale, before I'd said anything about all of this, would seem like an important change clinically. No one. Oh no, one person at the back. Good. It's good to be bold. And put your hand up if you think that's lower than you would think than you predicted it would be. Okay, good. I think it's surprisingly low. But the longer I spend in persistent pain, the more prepared I am to accept it. When they wrote this threshold, they also added the caveat that readers should caution against dismissing effects of less than 1-point change, which I find amazing. And it kind of begs the question, well, how low can we go on this? Actually, when we get below 1 point on a pain scale, we don't have the precision to detect those changes reliably anyway. And to some degree, this low threshold probably reflects expediency based on the fact that we know that setting it higher is kind of devastating to an awful lot of interventions. So how does this type of between-group threshold stand up compared to the impact threshold? Well, it definitely shifts our focus from statistical significance to effect size. It is not intervention-specific, it's generic. It's not population-specific, but it is at least based on the treatment effect and not just the patient outcome. So let's have a look at how our interventions hold up across the Cochrane Library based on that between-group difference. And you see a kind of, oh, sorry, I've gone ahead too quickly. You see a similar picture. I would caution against looking at this slide and saying, well, Pilates is better than manual therapy because we haven't got direct comparisons. And there's an awful lot of overlap of our imprecision. But I mean, the point I make it, look at opioids on here, tramadol and strong opioids. Not meeting our minimal important difference. Now, again, if you put that together with the risks and the potential harms associated with opioid use in chronic conditions, I think there's a strong case to be made that we shouldn't be using them. Across other conditions, here's exercise therapy versus other therapies, CBT versus usual care in neck pain, CBT versus usual care in mixed chronic pain, CBT versus usual care in fibromyalgia. There's definitely a picture emerging for CBT used as a sole treatment, that it isn't delivering big changes in pain. Resistance exercise versus usual care for fibromyalgia rather stands out, but if you notice, these very wide confidence intervals reflect that these are based on very small amount of data. In terms of CBT, though, there's a good argument to be made that the point of cognitive behavioral therapy is not to change pain. It is to help people to function better with their pain. And that's absolutely true, although when you look at the recent Cochrane review of CBT for chronic back pain, there were small effects on pain and absolutely astoundingly no effects on function. Complex regional pain syndrome now, this is from my own Cochrane reviews now, we see a slightly better picture. So bisphosphonates versus placebo, ketamine infusions versus placebo, and this is 5 to 10 days of regular infusions of ketamine. So it's quite an aggressive treatment. Physiotherapy versus a passive kind of attention control, and this is graded motor imagery. Are people familiar with graded motor imagery? It's a sort of brain training approach developed by Lorimer Moseley. So things are looking better in CRPS, but they're not really, because again, these estimates are based on a small handful of trials, unfortunately at quite a substantial risk of bias. So I would exercise caution when thinking that the picture looks better in CRPS. So we're left with this tyranny of small effects. And how do we negotiate that? What does it even mean for the between group difference in pain to be small? Well, what's hiding in that small effect? What could that small effect actually represent? Well, it could be that most people experience that small effect, that most people had an effect of less than 1 point on a 0 to 10 pain scale. And it could be that a very small minority of people experience quite large and important effects. And that certainly seems to be the case in some of our neuropathic pain medication. Doesn't help that many people, but a few people it helps a lot. It could be that a large group experience large effects, but another group almost of the same size experience substantial harm, to average at not very much. And it could be that there are no effects at all, and what we're really measuring is the inherent biases in those trials. And the truth of the matter is we don't actually have the answer to that at the moment. This is Professor Andrew Moore, who's one of the senior academics at the Cochrane Pain Group and was one of the founders of the Cochrane Pain Group. And he has a line that he uses in every lecture, which is the mean, and he means the mean average between group difference, is mean, that it's hiding something, that our treatments are better than that. And the examples that he gives come from the drug world in chronic pain. And that is that response, or rather patient outcomes, are bimodally distributed. And that's a bit of a fiddly concept. But what he's saying is, for most people with many drugs, lots and lots of people get no impact at all, have no effect. Not many people are in the middle. And then another substantial group of people have large effects. And so when you take an average of that, what you end up with is a very small effect, because those large effects in a minority of people are washed out by all the people who didn't respond. And if your outcomes are bimodally distributed, that's actually a really important thing. Whether outcomes are always bimodally distributed like that is another question. The solution to this is to stop taking the between group average, the proposed solution, and to do responder analyses. And a responder analysis basically means we'll count all the people that met our threshold of important change in the treatment group and all the people that met our threshold for didn't meet that threshold in the treatment group, and then we'll compare that with the control group. So if we set our threshold at a responder is someone whose pain improves by 50%, then we'd count the number of people in the treatment group who did that and compare it to the number of people in the control group. But the problem with that, as we've already said, is not all of those people will have responded to treatment. Some of them would have got that 50% anyway. It's a misnomer. It's a bad label to call it responder analysis, because we don't know if they're responders or not. And people start thinking language is important. So if you call it a responder analysis, everyone assumes that everyone in that treatment group who got better responded, which is inaccurate. And it selectively focuses only on positive change in symptoms, which is also a problem. So let's just take an example. Well, actually, just to show you, this is from Majid Artis's recent systematic review of back pain. They took all the reviews they could find of back pain interventions, randomly selected one treatment arm from those interventions, and just plotted what happened to their outcomes over time. And what you'll see, and in here you've got exercise, you've got manual therapy, you've got surgery, you've got drugs, and you've got no treatment and placebo. But what you'll see is that most groups in most trials there's a substantial improvement in symptoms in the first 10 weeks. That's a problem for a responder analysis because some of these arms have no treatment. You can't really respond to no treatment. So when we think of responders, we think, well, without the drug, your symptoms stay flat, and with the drug, you get a massive improvement, and that's what we're measuring. But let's think about different potential pictures we might get with a responder analysis. The green line is what would have happened to the patient without the intervention. The red line is the threshold for classifying someone as a responder. And the blue line is what would happen with the intervention. Now, in this instance, we would classify this person as a responder despite the fact that they would have responded without the drug or with the placebo, possibly even more so. In this instance, we have someone who improved substantially but just didn't meet the threshold. And then with the drug, they're tipped over the line. Now they're a responder. Now their pain is meaningful based on the arbitrary threshold that we set. But the effect was tiny. It was a small effect of the treatment. And when we do a responder analysis, we might actually just attribute all of that effect to the treatment. That's the temptation. But it's not true, actually. That's just representative of a small effect. But then we have this situation where the patient might have been getting worse. And this is what the drug did or the treatment did. In this case, the treatment has saved that person substantial suffering, but we would classify them as a non-responder. That's a precision problem, quite an important one, I think. And then I think this is the most worrying. And that is that this could have been what happened without the drug. And this is what will happen with the drug. In this case, the patient's getting worse, and they're getting worse because we're delivering an intervention. So that's iatrogenic harm. But we would just classify it rather benignly as a non-responder. Now, none of this means that responder analysis is useless, but it has substantial imprecision problems. So when we're worrying about the utility of the average between group difference and we switch to responder analysis, we also need to be mindful of the limitations of that approach as well. And if we have a look at how we've got almost no responder analysis data for physiotherapy or rehab, but we've got lots and lots of that data for neuropathic pain medications. So from a responder analysis, you can calculate the number needed to treat. Many of you will be familiar with that statistic. It's the number of extra people I would need to give the drug to rather than giving placebo for one more person to achieve a clinically important response. So for drugs like duloxetine, it's 6.4. Pregabalin, you might be surprised by this. Pregabalin, it's 7.7. Gabapentin, 7.2. The oldest and cheapest of my list of drugs, tricyclic antidepressants, 3.6. Strong opioids, 4.3. This is for neuropathic pain, and tramadol, 4.7. I think it's a really interesting graph. The NNH is the number needed to harm. So the number of people you'd need to give the drug rather than placebo for one more to experience a meaningful adverse event. And the grade column is the quality of the evidence for those judgments. If you look, we now have gabapentin and pregabalin. Really, they're the young kids on the block for neuropathic pain, and they don't seem to be better than what was there before. But actually, that doesn't mean they're not useful. And Andrew Moore's group came up with this great line: when you're treating anyone with persistent neuropathic pain or chronic pain generally, you should go in expecting failure, but pursuing success. That sounds a bit depressing. I don't think it needs to, because you just switch it around and suddenly it sounds positive. Pursue success, but expect failure. And the point of this is, if we know that for any of our drugs for neuropathic pain, the most likely outcome is that it won't deliver a clinically meaningful response, then we can monitor people when we put them on these drugs very, very closely. We know response when it comes will come quickly within the first few weeks. So where it doesn't come quickly or where the drug is intolerable, we can take them off that drug very quickly and switch them to another. We currently have no way of knowing which drug's going to help which person. So the best and most meaningful approach is to keep them on the drug for a short period of time. If there's no benefits, come off and switch to another. Then you get all the potential benefits of that patient receiving that drug, but you minimize the harms. And we move away from this situation, and you've all seen it if you treat people with persistent pain, of asking about their drug history, and they've been taking any number of different powerful agents for an amazing period of time, storing up all sorts of risk of adverse events, and not actually conferring any benefit from it. Of course, trials aren't universally accepted as the best way to measure effectiveness. And there's lots of people that think trials bias against our treatments, particularly in rehabilitation, in physiotherapy and occupational therapy. One of those things is the subgroup question, which goes back to a slide I talked about a little while ago, which is that maybe there's a small group of people in there that are benefiting. If only we can target our treatment better. There's this argument that in trials, we randomize patients to get a one-size-fits-all treatment. And that's not how we do things in practice. And that is true of some trials. But actually, physiotherapy and rehab trials have become much more sophisticated. Are people familiar with the Promise Whiplash trial from a couple of years ago? That's an amazing clinical trial where they developed a really clever best practice model of rehabilitation that incorporated exercise, advice, education, psychological support. And there was a manual. They trained people really well, and they allowed them to individualize that care to the individual patient. And they compared it to a single session of education and a leaflet. Now, that treatment is individualized, it's tailored, it's best practice. And the argument of a one-size-fits-all problem for that trial doesn't really stand. And the other one I hear a lot at conferences is that the real world's just too noisy. And we know we're helping our patients, but in trials, it's so noisy we just can't measure it. And that, I think, is fundamentally a flawed argument. Because actually, if our treatments are really helping people reliably, we should be able to detect that through the noise of everyday life. Because if a treatment only works under ideal, perfect conditions where everything's controlled, then it's not going to work in real life, because we don't treat patients in a soundproof room. We treat them in this messy world of competing events and influences. And there's something that you don't hear quite so often at physio conferences, and that is that the majority of our trials actually contain biases that favor the therapy that's being investigated, that actually should return effect sizes that are bigger than the truth. And that's not a speculative, that's quite well demonstrated. So, many of you will be familiar with the Cochrane Risk of Bias tool, or if not, the PEDRO tool. How many of you are familiar with PEDRO, the physio evidence database? And that has an 11-point tool for assessing the quality of studies. If you're not familiar with it, it's really great. Get on there, have a look at it, and start applying that tool to some trials, because, you know, as clinicians, the better we are at reading papers, the better we'll be able to serve our patients. But here's a few of the items on the PEDRO tool and also on the Cochrane Risk of Bias assessment, which is when we do a systematic review of trials, how we decide whether we should trust them or not, whether they're at risk of getting the wrong answer. Where trials didn't report randomizing properly, those effect sizes from trials that don't randomize properly are generally exaggerated by around 25%. And this is evidence coming from thousands of trials of many, many thousands of patients. Where there wasn't some sort of system of concealing the randomization process, which is where the real bias control comes in, from the person allowing people into the trial, that tends, where studies don't report that kind of process, effect sizes are generally exaggerated by 31%. And blinding, which is often impossible in physio treatments because the physio knows that they're delivering physio and the patient knows they're receiving it. It can't be placebo-controlled like a drug. But inadequate blinding, that exaggerates, for subjective outcomes like pain, that exaggerates effect sizes by 25%. The allocation concealment is the one that most people don't understand. And it's a great example of how, as human beings who want an answer, if there's capacity to just cheat a little bit in order to get the answer we want, we'll do it. So Bill Silverman was one of the fathers of the RCT, and he did one of the first RCTs in premature babies for retinopathy of prematurity. And it was an RCT of ACTH for that, and they didn't know whether it would work or not. And they had a very 1950s way of randomizing, which was to pick marbles out of a bag. And if you picked the white marble, you got the drug. And if you picked the black marble, you got no treatment. And he was doing his notes one day, and he saw the research nurse in the corner with a distressed parent bringing their child into the trial. And he saw the nurse pull out a black marble, look over both shoulders, pop it back in and pull out another one. And you can understand entirely why they would have done that. And when you're randomizing what healthcare someone gets, that's very emotional. So you have to hide that from people, because in the end, we're all prone to cheating. Size of trials really matters. I mean, really matters. Now, most of you from your undergraduate statistics will remember that if you've got a small study, then you're underpowered. And when you say you're underpowered, it means that you're at risk of not finding an effect, even if there actually is one. So what should happen then is with lots of small trials in therapies, we shouldn't be finding effects, even if they're there. But that's not what happens. There's a paradox here in that published small trials have a tendency to exaggerate effects. And that's quite hard to get your head around because it completely conflicts with what we know about statistics. Here is some data from my colleague Dries Hettinger's recent review, not actually recent anymore, review of exercise interventions for persistent low back pain. And these are the effect sizes, the difference in change. So this side of the scale means a positive effect, and this side means it didn't really help or it was harmful. And on this axis is the number of people in the groups. So what you see from small trials, what do you notice about the small trials? The spread of effect sizes. It's huge, isn't it? Is it huge and equally distributed either side of the line of no effect? Do you think? Or do you think there are more trials up here looking amazing? And then when we get the big trials, which give us our most accurate estimates of effect, they're down here. And that's a really interesting phenomenon. You think, well, how can it be if these studies are underpowered that they're showing bigger effects? How is that? Why would that happen? And this is the big reason. And that's publication bias. I don't know if many of you are familiar with publication bias, but it's one of the great challenges to health research right now, and psychology research actually. And that is that if you have a trial that doesn't show an effect or an experiment that doesn't show an effect with inconclusive findings, it's got a much lower probability of ever being published. Partly because the people who did the trial really wanted to find an effect, so when they didn't, it sits in the file drawer or the bin. Partly it's because it's really hard to persuade editors and reviewers in journals to publish negative results, even though we know if we don't do that, we end up with a very skewed representation of the truth because only the positive studies are published. This is a funnel plot, and it's one of the outputs we get from our Cochrane reviews. And we can actually go hunting to see if there's publication bias. Everyone's familiar with glucosamine for OA. Anyone use it? I'm a recovered user of glucosamine. So I had a nasty rugby injury years ago, and the evidence was looking quite positive for glucosamine, so I started paying for it. But as I became more aware of evidence-based practice and a little bit more skilled in it, I stopped paying for it. But anyway, this is a funnel plot. It's basically like that last graph I showed you, but turned on the other way. And what you do is you pull all the studies of glucosamine versus placebo together, and this vertical line is the effect size for placebo. This is the effect size here. So 0 would be no effect, and this is standardized mean difference. So this is in standard deviations. So the real effect of glucosamine may be about 0.2 of a standard deviation. But what you should see is the bigger studies, which are more precise, will cluster closely around that line. But as the studies get smaller and less precise, they'll spread out. But if there's no publication bias, they should spread out either side of the line. If they're only spread out on one side of the line, that tells you that small positive studies are the only ones getting published. I want to show you the conclusions of this review. Most of the observed heterogeneity in glucosamine trials is explained by the brand. Trials using the Rotterdam Madhouse glucosamine product had a superior outcome on pain in OA compared to other preparations. So maybe that's the brand you should buy. Except, look at the graph, the black squares are the Rotterdam product, and the other squares are the other manufacturers. Do you see any black squares on this side of the line? Not one. And that is the strongest evidence I've ever seen of publication bias. So it appears that negative trials of the Rotterdam Madhouse glucosamine product have not been published. That's really important for us because if we drew our conclusions just on the effect size for those trials and didn't do that, what would we do? We'd struggle with that. We would get the wrong answer. Okay. Of course, when you get people into a trial, they tend not to stay. So not everyone who starts a trial does what they're told, finishes the trial, completes the treatment. People do all sorts of things. They they swap to the other treatment, they don't adhere to the treatment, they just disappear and we can't follow them up. And it's hard to know what to do with that, particularly if we don't get data from those people. So we're left with the situation where we impute data, which imputation is a fancy statistical word for we invent data. We make data up. But what we're trying to do is make data up in the least biased way we can. But one of the classic ways to do it was to take the last observation carried forward, LOCF, which means the last time you measured that patient in the trial, all the empty spaces, you just plug that number in. It's that simple. The problem is, though, that people leave the trial after they've decided that the treatment isn't working for them, or after they've had an adverse event. And the last observation generally reflects a quite positive experience before they suddenly realize it isn't really helping me or it's making me worse. So by doing last observation carried forward, we're actually overestimating the effects of our studies and we're underestimating the potential harms of our treatments. So we need to find better ways to impute. There are better ways. One is baseline observation carried forward, where you just take their baseline measure and put that into all the gaps. But that's a problem too, because people get better a little bit, whatever you do, and you wouldn't even be capturing that. So it's too conservative. And then there's some fancy statistical ways of doing it, which seem to be better, except for the fact only statisticians understand them. For physiotherapy trials, we have the next problem, which is, okay, so I know that you delivered core stability or CBT or cognitive functional therapy or manual therapy. I know you did that. But do I really know what happened in that trial? And this quote from a journalist is good. The discrepancy between what actually happened and the version of what happened provided by sources is an enormous grey area. Tammy Hoffman did a review recently of trials and systematic reviews of complex interventions, and nearly all of our interventions in rehabilitation are complex. And they wanted to look at, well, were the interventions actually described in such a way that we could actually tell what was done? Could we replicate it? Could we apply it to our patients if we thought this looks good? And they found that only 39% of complex interventions were adequately described, and concluded that missing essential information about interventions is a frequent but fixable contributor to waste in research funding. And if we think about what happens in a rehab trial, it's complicated. This is a model from my colleague at Brunel, Meryl Norris, and some of her colleagues at the University of Exeter in the UK about treatment fidelity. And, you know, in a trial, really, you need to know what the intervention is. What's the dose? Exactly what's done in there? How is it tailored to the individual? You need to know, well, were these clinicians really adequately trained to deliver this to some sort of benchmark quality? Even if they were, you need some monitoring to make sure that they actually adhere to the treatment principles and don't just revert to what they normally do in practice, which often happens, particularly in big trials, over a long period of time. Did the patient even understand it? I don't know if any of you, do you know Kieran O'Sullivan, the back pain researcher from University of Limerick? Actually, he's just moved to the Aspetar in Dubai. He has a great test. The Kieran O'Sullivan test is when you've finished explaining something to your patient and you've taught them their exercises, ask them to tell you how they're going to explain it to their family when they get home. It's a fascinating exercise because you often don't get back what you think you got back. And, you know, with exercise, rehab, and complex psychological interventions, that comprehension barrier is often a big barrier. So did the patient understand it? And have they actually demonstrated adherence? Have they behaved in the way that you've asked them? This is very complicated, but ultimately it needs to be described, and often it's not. People might be familiar now, there's a new phenomenon called the TIDEA checklist. And this is now a checklist that most editors of most good journals are going to force new trials to meet, where all of the interventions are adequately described. So hopefully that will really improve things for the field. I've gone through nearly all the biases I can think about, except the ones we really wish didn't happen at all. The first one is misreporting. And this happens far more than it should. Discrepancies between the trial protocol and the published paper were found in 79% of analgesic trials. 30% of those were unambiguous, i.e. very unlikely just to be an error of reporting. Things like switching your primary outcome. So in the registered trial, you said my primary outcome is pain, but somehow it switches to quality of life. Why would you do that? Why would you do that? Because you didn't find an effect on pain. It's the surrogate outcome. Okay? It's very naughty. It represents a big problem for the field, and yet it happens. And it happens, well, far more than it should. But even if they report the outcomes, researchers being human beings, and often clinicians, they want a certain answer. So even if they don't quite find it, they might want you to think the answer is more positive than the one that they found. So Isabelle Boutron's group went looking for spin, which is a kind of modern term, isn't it, for exaggeration, I guess, in RCT reports. And they selectively looked at negative trials. And they took a bunch of negative trials and they had a checklist of things that they think are spin, like trying to say there's a difference when there's no statistically significant difference, or focusing only on a secondary outcome because you didn't find an effect on your primary outcome. There's lots of other versions. And they think they found spin in more than 40% of negative trials. 23% of rheumatology trials were judged by Matthew's group as having misleading conclusions, the same type of misleading conclusions. And the strongest predictor of finding a misleading conclusion statistically was that the trial didn't find a statistically significant effect on the primary outcome. And Jennifer Gewantner's group have just found signs of spin in the abstract of 61% of negative analgesic trials. We need to be aware of this, and it speaks to a bigger issue that as clinicians, we are users of evidence. And what I'm trying to show you is it isn't enough to just read the abstract and take that as read. We all need, I think, to really work on our scientific literacy so that we can actually make critical judgments of those papers ourselves. If you're ever reading a trial and you think something might be awry, well, the trial registry document is a public document. And sometimes they've published a protocol. It's actually quite interesting, and it's a fun bit of detective work to go back to the protocol to see if it matches up. And you might be surprised. Harms are a big issue. Underreporting of risks has been an issue in pharmaceutical trials, but the pharmaceutical industry at least have to compete with regulators about that. But in non-pharmacological trials, we don't have regulators. And in non-pharmacological trials, we have a real lack of reporting of adverse events. We don't know how they were measured. We don't know how many they were often. I think as a maturing group of professions who really have a commitment to patient care and better evidence, we absolutely need to be aware that if we can help people, then we can harm people. We need to measure that to be sure that we're not doing it. So just coming towards the end, a little rogues gallery of things that you could look for in trials that aren't necessarily captured on the Pedro tool or the Cochrane risk of bias tool. So pick up a trial this week, have a look, and see if you see any of these. One of my favorites, because it happens so often, and it really should never happen at all, is you have one trial comparing one intervention next to another intervention. And there's no statistically significant difference between the interventions. And importantly, there's no placebo or no treatment or usual treatment group in that trial. And they conclude that there's no difference between the treatments, but both were effective. That's simply not true. It might be true, but you cannot infer that because there's no usual care group. It's very, very cheeky, and it happens a lot. The surrogate outcome gamble, where you don't find the difference that you want on the outcome of importance, so you go looking for an outcome where you might find a difference. Post-hoc subgroup hunting, where you didn't really have a theory about there being specific subgroups of responders when you started the trial, but when you found a small effect or no effect at the end of the trial, you go hunting to try and find out those people who benefited. They're not the people who benefited. They're just a subgroup who get better anyway. And they're generally the people with lower pain and lower distress at the start. That's not a treatment effect that you're measuring. There's a new phenomenon people are becoming more aware of called p-hacking, which is cheating p-value testing. And the way you do that is we know that if we run a statistical test, in theory, p equals less than 0.05 means there's less than a 5% chance that it's a false positive. What if I run 10 tests and one of them comes up, p equals less than 0.05? Well, now there's a 50% chance of a false positive. So if you run enough tests, you'll find a positive. And there's an old statistician's idiom that if you talk to your data for long enough, it will confess to something. And that's true. The more p-values, the more tests that you do, the more chance that you'll find something. And the last one, and this is just fabulous to look for, because when you spot it, you'll feel pleased with yourself, is axis cropping. I want to give you an example of what I mean. This is a paper that I reviewed a few years ago of non-invasive brain stimulation for chronic pain. So it's transcranial magnetic stimulation for chronic pain, which means you put a magnetic coil on the head, passes strong magnetic fields which generate an electrical field in the brain. Anyway, this is real TMS versus sham for fibromyalgia. And the solid line is the real treatment and the dashed line is the sham treatment. Does it work? Looks good, yes? It looks good because you can see statistically significant differences here. How do we normally measure pain? What scale do we use? We use a VAS, right? And how many numbers on the VAS? 10. How many numbers on this one? 2.5. What? Who ever heard of a VAS scale that went from 3.5 to 6? So they've cropped 3/4 of the scale off. Why would you do that? Well, we looked at that and we said, look, I think this is a really important trial. It actually is an important trial. We would support you publishing this trial, but we would like to change the conclusions to RTMS delivers clinically unimportant benefits. And we'd also like you to not crop your y-axis. This is the published graph. This paper did get up in that very good journal. And the conclusions of the abstract are very different from the conclusions that first came out. And importantly, this is the same data. There's no good reason for cropping a 0 to 11 pain scale. It's not like you can't fit it on the page. The only reason is to make the difference look bigger. Now, sometimes I give this talk or similar talks and I feel like maybe I'm being a bit downbeat. And it can seem that this kind of level of scrutiny, small effect sizes, lots of bias, it's a bit miserable. It's not. I think it's profoundly positive. Because if the ultimate goal of practice and evidence-based practice is to drive innovation, is to allow us to know where we're not succeeding as much as we think we are, that and how we can start to get rid of the things that maybe we traditionally have done that aren't helping, and we can focus on the things that are. We know there are some treatments that help a little bit. Maybe we can improve those treatments to help them, to work better. One of the things I'm very excited by is there's emerging evidence that combined physical and psychological rehabilitation seems to be better than all the things we've had in trials until the last few years, which is just psychological therapy or rehab. But combining those, I mean, it's early days and it's definitely not for certain yet. But the reason we're at that point is because we have negative data to drive us to improve. So it's actually profoundly positive. And I'm reminded of the physicist Richard Feynman's quote. And he wrote this quote after being involved in the investigation of the Challenger space shuttle disaster. And he was very frustrated that he felt that people in NASA had been a bit too positive, the power of positive thinking, and hadn't reflected enough on certain risks or more uncomfortable truths, and that may have increased the risk of the disaster. So when they submitted the report, he submitted a minority report attached to it. And this quote, I think, is just beautiful. For any successful technology, reality must take precedence over public relations, for nature cannot be fooled. What I like about that is every intervention we do is a health technology. But our responsibility before we really unleash it on our patients en masse is not to be fooled by all the reasons that we want it to work, but to really test it as well as we can. Archie Cochrane is one of the founders of modern epidemiology and the man after which the Cochrane collaboration was named. And he wrote once, "One should be delightfully surprised when any treatment at all is effective, and always assume that a treatment is ineffective unless there's evidence to the contrary." If that sounds shocking, I don't think it is. What that basically is the principles of null hypothesis testing. Propose a hypothesis, expose it to the severest scrutiny, and if it still stands, it's probably true. Sometimes in healthcare research, you look at the spin and the biases. We're not doing that, I think. I think what we're doing is trying to support the hypothesis, when what we're supposed to be doing is to try and prove the null hypothesis. And if we can't, then the hypothesis stands. It's fundamental science. But I think if we all reframe that, realize, particularly in persistent pain, we've set ourselves the hardest challenge. We've set ourselves of helping the people we've failed to date. Then we've got to realize that that's a stiff challenge. We shouldn't be surprised when we're not quite there. And that will help us keep pushing on. But we should never stop looking to be delightfully surprised. I want to thank you very much for your attention and listening. I hope it was useful. I'm happy to answer any questions at all. And thank you so much for the invite as well.